from one pipeline, the machine takes the blood to the directly to the means the pump actually takes the machine takes the blood from body to this dialyzer where the filtration takes place, and again the blood is flown to the person with the help of this pump only. So the dialyzer you will be able to see on the extreme left side upper corner. Here the dialyzer is there, and there is a counter current mechanism for the dialyzer. Matlab inside the dialyzer, this is a dialyzer is basically a hollow fiber dialyzer where the blood is flown across one means along one side of the membrane, and at the same time the dialysate flow is there. Dialysate means it's a solution basically which is composed of urea it is a constituents. Its contents are glucose, then sodium, potassium, and some buffering solution like bicarbonate is there. There is no urea or creatine, other toxins are not there, and it should be almost equal to sterile or distilled water. Almost, why I'm saying ki, because it's basically RO water only, which is being prepared in the RO machine there in the dialysis unit itself. So the RO water is basically made dialysis solution with the help of different constituents, and across one membrane means on one side dialysate fluid is there. Next slide, I'll be able to demonstrate that. Next one. This is the principle. So here on the right side dialysate is there, which is flowing from down to upwards, and the blood is flowing on the left side from up to down. So this is a counter current mechanism. They are flowing in the opposite direction so that the maximal effect is there, because if they flow in the same direction at the midpoint, the concentration of particular constituent will be equal in both the compartments, and the voltage will be zero and grading will be zero, and exchange will not be there. So to make the exchange possible throughout the period of throughout this contact time, we need to make the exchange possible. So that is why, and the mechanism is also there naturally. The God has created the counter current mechanism inside our kidneys also, so that maximum extraction of the fluid, maximal extraction of the different toxins are there. So previous slide, so that I can demonstrate them. Previous one. Here actually, this fistula is there in the right upper corner, has been shown where one artery and one vein, they are basically ligated with each other, and the art means with this fistula, after maturation of the fistula, arterialization of the vein takes place. So during fistula pricking, we prick this vein, this arterialized vein at two places at some particular distance apart from each other, and from one place the blood is drawn inside the machine, and at other place the blood is flown inside the body, and this is how the fistula works actually. So initially we have to create one fistula by artificially creating it directly, means ligating them, and after say 6 weeks or 2 months, the maturity takes place. Maturity means the vein has to become similar to artery, because veins are thin walled, veins are superficially placed, so they can be easily accessed. Because arteries, we cannot directly prick the arteries, because arteries, they have a lot of blood pressure inside them. Veins do not have. So again, some good effects are there, some side effects are there. Good effect will be able to prick that vein easily because they are superficial, and after maturity they will be easily visible. Arteries are not that easily visible, and again the pressure inside the vein will not be too much as equal to artery. We want to make them full with the pressurized blood, but not equal to that of the arterial pressure. Next one. So this is a hollow fiber hemodialysis filter that is called dialyzer, and the in the tip one, and means one side knob is there. So at point of at the center actually, the blood connection is there, and at the sidelines the dialysate connection is there. Next one. Again that fistula has come. So here vein and arteries are joined together and bypassing the blood which was expected to go throughout the palmar region, it directly going inside the vein, and with maturation the vein becomes similar to arteries. We can prick directly. When the arterial condition, vascular condition is not good enough, so we have to go ahead with the some AV graft, arteriovenous graft. Synthetic material has to be placed, and some of the population we can go ahead with the AV graft also, those who are able to afford that. And the right one, it's showing the schematic diagram of the hemodialysis catheter directly placed inside the internal jugular vein on the right side in this diagram. And two different types of the catheters are there, temporary catheter and permanent catheter. I'll be showing in the next slides. Next slide. So here the fistula, again how the fistula is being pricked and hemodialysis is going on with the help of AV fistula. Next one. So which type of the access is best one in the hemodialysis patient? The answer is fistula, because the fistula they survive most with the least complication. Next one. Answer is visible in the next slide. Yeah. So the fistula the best one because the infection rate is too less with the fistula. Thrombosis rate is too less as compared to graft. Infection rate is too less as compared to the accesses like internal jugular vein, means catheter, different catheters. So when the person reaches ESRD stage, so some guidelines are there. They are basically famous among the nephrologists, but even the non-nephrologist people should know when the GFR is too low, so his non-dominant arm, his or her non-dominant hand should be secluded. It should be preserved for future AV fistula or AV graft, which is whichever applicable. So the arm, when suitable for the placement of the axis, vascular axis, should be preserved regardless of the arm dominance. And the arm veins, particularly the cephalic vein of the non-dominant end, should not be used for pricking, for taking blood pressure. It should not be used for, so casual use should not be there. If it is too emergency, we can go ahead with it, but casual use should be avoided. Again, the dorsal arm of the hand can be used, but the front of the hand, in the anatomical position, the front hand is the end, so it should not be. The dorsum can be used. Generally, some guidelines should be there in the, if you are working in hospital, if some doctor is there, he is a nephrologist, his patient comes to the doing casual cannulation, IV cannulation should be avoided. Subclavian vein catheterization, again, it was famous in a few decades ago, but not too famous right now, because the internal jugular veins, they are easily accessible. And again, guided catheter placement is possible inside in the internal jugular veins, and it is not that easily possible with the subclavian veins, because ultrasonography, we can put the probe here, we can see what we are doing, where we are going inside the, while dealing with the internal jugular vein. But while doing subclavian, it will be a blind procedure, and again the complications like stenosis is too much with the subclavian veins. That is why this subclavian vein should be used for catheterization only if other options are left out. Thank you. Sorry, next slide, please. So save the non-dominant hand for vascular access when the GFR is below 30. So what we need to do? No pricking, no BP measurement, no blood should be taken from the non-dominant arm while the patient GFR, and place the vascular access at least 1 year when you anticipate hemodialysis will be required. This happens very rarely in the Indian population. 1 year ago कभी नहीं होता ऐसा. But ठीक है, कुछ लोग मानते हैं, some people they agree, and they are, some advantages are there. If the emergency is there, admission is required, too much of the money is required, and if this fistula is already ready, so whenever the condition arises, dialysis is need is there, so we can ask you go to some center, there you get the dialysis done and go home without having any complication. But again, the complicated of the patient, matlab, those who try to save money, those who do not agree, those who do not follow, they land up directly in the emergency, and everything will be done after. मतलब कैथेटर भी होगा, फिर उसके बाद फिस्टुला भी होगा, सब कुछ खर्चा लगेगा. बट अगेन द इंडियन पॉपुलेशन, इंडियन पेशेंट, वी हैव टू, मतलब it's very difficult to counsel, and again their own problems are there, that different matters.